pleasure to introduce Dr. Hisham Abu Taleb, my dearest friend and dearest professor, coordinator of gynecology unit in Asyut. Lecture Ovarian Cancer.
Okay, come in. Thank you very much for allowing me to present about the real-world data from the MEMAGO region. Actually, it was difficult to find a lot of data about this. I am Hisham Abu Taleb. I am Associate Professor of Gynecology. I am from Asyut. To who doesn't know Asyut, this is a small city in South Egypt. But actually, it has a good university, a big university, and we have established 3 years ago a gynecology unit with Professor Ala Ismail, and it was addressed in the International Journal of Gynecologic Cancers 1 year ago. This is our region, the MEMAGO region, which comprises a large amount of land, but it is a flat land with no boundaries. This allows the different ethnic groups to travel all over the years, have ancient civilizations with the Mediterranean Sea in the middle, which allow traveling. And so we can't say that there are different ethnic groups rather than this mixed race that have been mixed all over thousands of years. But if we look for this region, it is highly heterogeneous. For example, for the income, different than the other parts of the world. We'll have some areas with a high income, some areas with a low income, some areas with a middle income, and this heterogeneity impacted the healthcare systems and healthcare outcomes, as we will see after that. Regarding ovarian cancer, it is the 7th most common cancer worldwide, and actually it is the 8th most common cause of death from cancer in women, with estimated around 3,400 cases newly diagnosed each year, and 2,000 cases will die from ovarian cancer each year. If you look for the epidemiology, and these data are from the Globocan, we will find that the most incidence, the highest incidence in the world in the Northern Europe. And if we can go to a deep insight into our region, we will find that also there is a heterogeneous incidence. But actually, we can say roughly that the incidence reaches between 6 to 9 per 100,000 per year. Regarding the mortality, also the highest mortality may be because it occurs in higher incidence in the northern part, but the mortality is slightly lower. But due to the diversity in the healthcare region, if you look inside, we will find that the mortality rate is higher, reaching more than 5 per 100,000 women per year in our region. So why the mortality is higher in our region? We know that the cytoreductive surgery till the no visible lesion had the greatest impact in the overall survival for ovarian cancers. And this requires good healthcare system and good training program. What about the gynecology fellowships in our region? To my knowledge, there is no approved national training program in our countries, just discrete per institution programs in few centers in our region. The ESCO has defined standards for training for gynecology subspecialty, and already 140 centers have been accredited. In our region, only 9 centers are accredited in Turkey, and 2 in Egypt, in Mansoura and in Alexandria, and also they were individual efforts from Basel and our group in Alexandria. Regarding the advanced centers for advanced ovarian cancer, there are 80 centers who were accredited, 3 in Turkey and 1 in Lebanon, thanks to the efforts of Professor David Atallah. So after that, what we can do in MEMAGO or in other societies to improve the health care for ovarian cancer? Last year, Professor David have awarded the Award of Excellence in Teaching for his virtual tumor boards through the MEMAGO in collaboration with the IGCS, and actually he helped in teaching and in giving advice for the management of several cases. Also, I can't tell that without thanking Dr. Sarah Nasser, who also did a collaboration with the IZHS through the PARSGO to give virtual tumor boards, monthly boards, and also Dr. Basil, who through his center, he did weekly meetings for teaching, and he allowed it free online to all who can attend, so he improved the knowledge about gynecologic oncology. I here to refer to the review article which was published in Cancer last year about improving the quality of care for patients with advanced cancers all over the world. And it categorized several domains. Each domain has a barrier and recommendation to improve the quality of ovarian cancer care. The first of it is the care of and coordination of the patient educations. And the main barrier was limited physician time for the non-medical needs for these patients. And the recommendations to improve the barrier is to provide resources, either local or online for the patients, and to incorporate what is named as a patient navigator that can provide the patient with those needs. The second is the prevention and the screening. I came from Asyut, you know all Professor Mahmoud Sathalla who passed it here, and Professor Mahmoud Sathalla is the inventor of the theory of incessant ovulation that gave that contraception may reduce the incidence of ovarian cancers. And now we all know the theory of stick, that the origin of epithelial ovarian cancer is from tube, and so the opportunistic self-injectomy may improve in reducing the risk of ovarian cancers. And so such cases, and we to continuing educating the gynecologist about this is very important in reducing the risk of ovarian cancer in our region. And also we have to provoke our pathologists for thorough evaluation of the specimens for detection of occult cancers. The diagnosis and management, there is usually lack of access to the gyne-oncologists who are specialized, and there is a fragmented care, and this was addressed in our discussions in the last session. And we all agreed that we have to do just assign local gyne-oncologists in each area for referral, and overcome the barriers to access for these gyne-oncologists, and bridging the cancer care centers and services for the patients so as not to miss any. Also the availability of the treatments. Actually, the treatment is available, but what we suffer is that there is a financial toxicity from oral to the chemotherapies, and also there is a low rate of prescribing target therapies. And in order to overcome this, we have to engage some, what we can say, a financial navigator to assess the patient for out of the pocket costs, and also to educate the healthcare providers about the efficacy and when to use the target therapy in the proper place. And also we also suffer from the overuse or the misuse of imaging in patient surveillance, and so we have to implement the quality metrics to involve the evidence-based surveillance. In conclusion, although lacking a solid registry system, the MEMAGO region is one of the highest mortality rates in ovarian cancer, and still there is a long way and effort is needed to improve the gynecologic and ovarian cancer services in our region. Virtual tumor boards is a good step towards equality and improving the cancer care, and tackling the different barriers and making action plans for delivering a high-quality ovarian cancer care delivery is crucial. And I ask the MEMAGO and the other societies to have action plans in order to implement such cases. And thank you.